Hi, I'm Randy Reid, Executive Director of the National Lighting Bureau, and welcome to our series, Let's Talk About Light and Health. It's a collaboration between the NLB and Mount Sinai's Light and Health Research Center. Today's topic is Bright Light in the Day Improves a Hospital Stay. I'm joined by Dr. David Reich, President of the Mount Sinai Hospital and Mount Sinai Hospital Queens, and Dr. Mariana Figueiro, Director of the Light and Health Research Center. Now, you can submit questions during the discussion by clicking the Q&A button, and the panel will address those questions after the presentations. Dr. Rich, Dr. Figueiro, welcome.
Thank you,
Thank
Randy.
you. Pleasure to be here. Thank you.
I'm so glad to have you both. Dr. Rich, tell us a little bit about your role as president of the Mount Sinai Hospital and Mount Sinai Hospital Queens.
Well, just a little background in that I've been at Mount Sinai for getting close to 39 years now. I came as a resident and then eventually became chair of the Department of Anesthesiology, and for the last 10 years have had these hospital positions, the president of the two of our now 8 campuses. And I think the key thing to keep in mind is that programmatic development is a very important and frankly kind of fun thing to do as a hospital leader. And so, as an example, we built an Institute for Critical Care Medicine where we combine the critical care units from all the different departments into one entity. And we've also built some artificial intelligence tools that tend to activate teams of people to get them to the right patient at the right time. And these innovative efforts create a great spirit. And I'm also blessed in that Mount Sinai Hospital, Mount Sinai Queens have been effectively one hospital since 1999, long before I was involved at the leadership level. And because of that, it's a very cohesive and collegial relationship between the 2 campuses.
Okay, thank you for that. But I need to back up on one thing. Can you explain a little bit about the AI teams and how that works?
Oh, for example, every day we send a list that's generated by an AI algorithm to our dietitians. And we tell them which patients in the hospital are most likely to have malnutrition. And they're about 3 times as likely to diagnose malnutrition now because we send them to a very curated list. We do the same thing with our delirium team. We're doing the same thing now with the psychiatry team related to a predictor of agitation and violent behavior. And we've also put other algorithms in place that we're now rolling out on a wider basis to see if a patient's having clinical deterioration, getting sicker, and might need to be taken to an intensive care unit. So that is the latest.
Okay, that is fascinating. Okay, Dr. Figueiro, as the director of the Light and Health Research Center, what gets you up every morning to do your job? What are you most passionate about when it comes to light and health?
Well, and it is the reason why I came to Mount Sinai is I love to help people and increase the quality of life of patients. And I think no better place than being here at Sinai with the ability of getting to know different people almost every day. Like today, we were talking to Alex, who runs the Autism Center here at Sinai, and talking about how we can use light to help autistic kids sleep better. And he said, nobody has given me an opportunity to give them a non-pharmacological intervention. It's always about drugs. So he was excited with the possibility of doing that. So having all that, I always say that I'm like a kid in a candy store, all the opportunities of collaborating. And that's really what gets me out of bed and gets me to work every day.
Well, can you explain a little bit more detail about how light helps people with autism get better sleep?
Well, that light is the main synchronizer of your biological clock to your watch, to the local time on Earth. So a lot of times what happens, for example, I'm using autistic kids, but we're working with Alzheimer's patients. We're also doing some work with cancer patients. A lot of times they're in dim light all day. So if you think about today, it's a beautiful day here in New York. But if we're indoors, we're not getting that much light. And we're really designed to get this high amounts of light during the day, low amounts of light during the evening. So what's happening is we're actually getting this muted light where we're getting dim light constantly day and evening. So what we're doing is we're giving them this robust light dark pattern in a very passive way. So in other words, wherever the autistic kids are spending most of their day, we're going to change the lighting there so that they're getting that light without having to sit in front of a light box, for example. And that more light during the day helps you sleep better at night. And then once you sleep better, everything falls in place.
I agree. Dr. Rich, as president of one of the largest and I guess most prestigious hospitals in the country, what are some of the important metrics that you look at regarding patient health care?
At the highest level, it's the classic metrics such as the length of stay in the hospital, the observed to expected mortality, outcome in the different areas, such as cardiac surgery or neurosurgery, medicine patients. And so we follow a huge number of metrics every day, every hour, it seems. And the key thing here is that we have a very scientific approach, because one of the blessings we have on this main Mount Sinai Hospital campus is that we don't know where the School of Medicine ends and the hospital begins, and vice versa. And so with this strong collaboration, we can have these collaborations like the ones that we're having with Mariana.
Dr. Figueiro, can you explain how lighting can have an effect on these metrics that Dr. Rich has mentioned?
Yeah, I mean, one of the projects that he's referring to, it's actually related to falls risks. So Dr. Rich actually totally sort of approved and supported one of the demonstrations we're doing, where we're using horizontal and vertical lights to try to minimize falls in residents' rooms. We have some data from lab studies. We also have data from assisted living facilities with Alzheimer's patients that it reduces falls by 34% by having these visual cues at night. So we installed in the rooms and we're starting to collect data right now. In fact, today we finished the last room. We expanded from one floor. The nurses found out, and they as part of the nurses council, they decided to do additional rooms. So that's just one example of how, in addition to helping people sleep, which is another project we're doing, for example, with myeloma transplant patients, where we're putting lights in the hospital room during the transplant. And we're just starting an NIH grant on that. So we're working with the myeloma transplant group to recruit the subjects and to deliver that light and look at outcome measures such as sleep, inflammation, symptom burden, to try to see if we can improve the patient's quality of life.
Well, reducing falls by 34% is a staggering number.
Yeah, yeah.
And wow, that is incredible to hear. So let me ask you both, you know, in the lighting industry, we talk so much about light level, about energy and cost. What can we as an industry do to kind of incorporate lighting for better health care?
So I'll start. It has to be easy for the staff to manage. So if there is, for example, a pre-programmed timing mechanism that adjusts light based upon things such as when sunrise or sunset occurs, or other sort of milestones during the daytime, that would be great. But the thing that we cannot have is, let's say you have a nice fancy control in the room, and there might be 10 or 15 different settings. We cannot expect our staff, all of them, to become expert in this. So to the extent that we can have central programming and operations, that would make it more practical as we move beyond doing these pilot investigatory rooms.
Okay,
Yeah.
Dr. Figueiro?
Yeah, I totally agree. I think that, well, first of all, I think we can have very simple bright days, dark nights in patients' rooms without being any complication or anything, just by, I think, changing the lighting to account for the sensitivity of different systems that we have. So for example, visibility is different than how the circadian system responds to light. So if we can make sure that we affect both. The other thing is that we have to think about, patients are sitting in bed, laying down, looking up, right? So there's glare, there's discomfort. So how do we take that into account? How do we design taking that into consideration? I think the technology in lighting has evolved to a point where anything can be done, including simple controls and things that the nurses don't have to think about to be able to do it. So I think that if designed correctly, it can help with visibility, it can help with postural control and stability, and it can help with improving sleep. And obviously,
and go ahead.
Yeah. And if I could also supplement, I think patient level of control is also fairly important too. It's when I'm, technology's at the point now where I'm at home, I can tell, my speakers to play Baroque music, and I can tell it to increase or decrease the volume or just to shut up. And so why shouldn't our patients also have, voice recognition ability to control aspects of their environment, including the lighting? I would also add their communication devices, etc.
It was interesting because one thing that I noticed in hospital beds now, they have USB ports for you to plug in and charge your phone, right? Mm-hmm. So you think about it, we have evolved already to do that. No, we need to do the same with the lighting. We have to be able to evolve to a point where the patients can control their lighting, can make the lighting comfortable, but can also receive the lighting they need throughout the 24 hours because the needs change over the course of the day. So we need to have the ability to deliver that.
You mentioned about giving the patient access and control, but also centralizing control because there are certain types of light they need. Isn't that kind of a contradiction? How do you allow the patient to control the light because they may not do what's in their circadian best interest?
Layers of light. You have your base light, which is providing you what you need, and then you have more of task-oriented light that allows the patient to control. Now, having said that, with for example, the patients, the cancer patients, we're really giving them the light between 7 a.m. and 10 a.m. and then we're turning it off because these patients don't want to be in very bright light all day. They're very sick. So there are going to be patients that are going to be very sick and they're going to opt not to get it. But if we can educate them and tell them, hey, get it for at least an hour in the morning and then you can control the light. But if we can give them that information, because they don't know, and I'm sure if you give them that information, said, hey, if you get an hour in the morning, you can sleep better at night, I'm sure they'll do it. And then they can control whatever they want.
And going back to the industry requirements, I think it's also critical that we think about how this integrates with existing hospital systems. And we talked about maybe something that was pre-programmed, but for example, we use a tool which was developed through the Epic electronic health record. We relabeled it as My Mount Sinai. So there's also My Mount Sinai bedside. So when someone is in a hospital, they actually have a device. And if they choose to activate it, they can use that device to order food, or they can control a bit of a schedule. They can see their medications. And so if we try to come up with a separate system for lighting, it'll be much more difficult for us to implement. And so think about, what the current environment is in terms of the data flow in a patient room, where the hospitals have made their investments, which are very significant, and do your best to make it part of that process. For our food ordering, we actually do have a separate vendor, but we were able to integrate it into the Epic product. So I think it's critical that whether it's an Epic hospital or a Cerner hospital or around the nation or around the world, there may be many different systems, figure out what those top systems are and find a way to play nicely in the sandbox.
Now, let me say, adding to that is very interesting. One of the things that we always complain is that lighting, people don't talk to people outside lighting. And if you want lighting to be part of hospitals, you need to start doing that. Exactly to your point, is that you have to talk to the big guys doing the hospital, systems, and you have to be part of the team, or else you're not going to make any inroads in hospitals. This is a really, I think this is a very important point that we need to remember.
No doubt. And you both talked about the importance of the lighting, of the effects of lighting on the patients. What about the effects of lighting on the staff?
Well, we know that we can actually help the staff with the lighting, and the lighting for the staff during the daytime will be different than the lighting for the staff at nighttime, because you have different needs at night. This is a much more complicated solution, but we have been doing work with shift workers, and we're showing that there are lighting solutions that can help them stay healthier, stay more alert during the work, especially the night shift, and sleep well when they get home in the morning, which is always the challenge. So we are about to actually start another project with emergency department group that does the training. And we are going to be looking at solutions to help with increasing alertness and reducing disruption of circadian rhythms in shift workers. So there's a lot of room to grow there.
Sure. Okay, Dr. Rich, any closing comments?
Just that it's really wonderful to be having this dialogue, and that I think it's very important that your membership get into the healthcare setting with, obviously, with permission and an appropriate, stewardship of the visit, but to get in and see what the hospital rooms look like, see what the problems are, because the visual is very important. I do a lot of rounding, and I think it's important for your team as well. Get out there, walk, see what you're talking about, talk to the staff about their problems, and you take a lighting focus to it, of course, but it's going to be better on the ground.
Dr. Figueiro, closing comments? Well, I agree. And I think that integration is important. I think hopefully we'll be able to use the research to teach people, or at least to inform the lighting industry on what can be done and what cannot be done. But in the end, the application and the real life situation is tough. There's a lot of things that need to go into when doing a hospital, construction and hospital lighting. So we keep working, and I'm very happy that I had the opportunity to come to Sinai and continue to work with the great team we have here.
Okay, well, thank you both, and please stick with us as we will now open the floor to questions.
Welcome, everybody. We're glad you're here. Dr. Rich, Dr. Figueiro, thank you so much for being our panelist. I would like to now introduce Allison Thayer. Allison is with the Light and Health Research Center, and she's the producer. She puts everything together for us. The floor is now open for questions, and please do use the Q&A button to submit your question, and then we will unmute your mic, and then you can ask the question yourself. While we're waiting for those questions, I want to remind our audience, our next webinar in our Let's Talk About Light and Health series will be on 22 May, Getting the Job Done, Lighting for the New Office Paradigm. And that will feature Dr. Mark Ray and Kevin Kampscher. And that will be 22 May, which is the Monday before Light Fair, and that starts at 12 p.m. Eastern. So Allison, let me turn it over to you to see if we have any questions.
If the idea is to establish a rhythm of light-dark for inpatients to encourage better sleep for healing, how should we address interruptions in the middle of the night when residents enter patient rooms, turn on bright light, and leave without turning them off? This person said it happens a lot, actually. So is there a way to educate the residents and interns about lighting?
I don't want to come across as too grumpy, but it doesn't happen a lot. If it does happen, it just requires correction, and the staff can turn the lights out. I just, I cannot, let it go said in front of this large group that this is a common problem. It's a rare problem.
Yeah, and I think also the solutions we're testing with the horizontal vertical lights, they are night lights, and they provide plenty of illumination for the nurse to come in and out without having to turn on the lights. One thing that we also notice is that at night, the curtains are pulled so that any spilled light from the corridor, it's actually minimized in the rooms. I think that people are aware of it, and it's starting to happen, but we think that maybe the night lights will help even further. To a point in the discussion is we don't want the nurses to have to think about it, and if we can make it easier on them, I think we should as lighting professionals.
All right, so we have a question by Richard White. Would you like to be unmuted to ask your question?
Hey, good morning. Thank you for the conversation. My question is, I'm a member of the California Senior Legislature, and I'm working on a proposal that would address aging in place initiatives in the residential setting. And looking at your proposals in healthcare settings, how many of these lighting proposals could also work for folks that are aging in place and while improving their lighting in the home as well?
I'll take that. I would say all of them. In a way, we have worked in some of our NIH grants with older adults, both at home and in assisted living facilities and nursing homes. And basically, we're working with what we call a 24-hour lighting scheme for older adults, which is improve visibility, because we know that as we age, we need more light, we're more sensitive to glare. So there are lighting techniques that can help them see better in a more comfortable way. And we're also looking at lighting that it provides that bright days and dark nights to help and train the circadian system. And then finally, the horizontal vertical lights as sort of night lights for minimizing risks for falls. All of this can be used both in healthcare facilities as well as at home or in assisted living facilities and nursing homes.
So what is one of the most impactful findings in helping patients with lighting and recovery?
Well, I have to say that the research is new, and we're starting to do all of that now. We have shown, I think, one of the most impactful results we've had has been with the cancer patients. So we have data from patients undergoing the myeloma transplant that we gave the light inside the hospital room, and we did see that they reduced depression, they reduced inflammation as measured by inflammatory markers. There was a hint, and again, we're doing the larger study now to see if we can replicate that, but there was a hint that they were perhaps a day reduced a day in their hospitalization. So I think that, right now that has been what we're pursuing, is trying to replicate and increase the population in the healthcare environment to be able to show those benefits. So it's young, but we're getting there.
Do Mount Sinai have patient rooms that could serve as a best practice model for other healthcare institutions? Kind of what we were talking about with some of the studies that are going on right now.
It's pretty early in the process. We've just installed lighting, and Dr. Figueiro is going to be doing research in those rooms. So I think it'd probably be prudent to make sure that it's having the desired effect before we put it out there as a best practice.
Definitely. And it seems like with having inpatients being there longer, we can see more of an effect probably with longer term inpatients than people who are in the hospital for just a couple of days. Do you have any comments on that?
Even short stay patients, you can have people who are prone to delirium, based upon age, medications, other medical risk factors. So I wouldn't want to diminish the importance of good lighting on safety, even for short stays.
I totally agree. I mean, I think that it depends on what you're looking at. If you're looking at a circadian rhythm impact, it may be that you need a little bit longer stay. But again, a lot of what we see, I think it's a very interesting way of looking at. It's not that you're improving their sleep, for example. What you're doing is you're maintaining good sleep. So they come in, they're synchronized. And what you do with the lighting is you maintain that synchrony so that they don't get worse by being in a constant dim light, for example. So in a way, it's a preventive. And that's, for example, with delirium, people that have delirium, they already come with that tendency to perhaps be more sensitive to that. So if we can prep them before they come to the hospital and then during hospitalization, even if it's a short stay, I think there is a potential to be beneficial. And again, that's what we're working with Mount Sinai to start showing those ideas and start demonstrating these new ideas.
So we have another, I think, really nice question from Lori, and it's how does a designer make arrangements to access hospitals to understand the lighting needs, or how is there a way for designers to really understand the needs of, because there's a lot of different types of patients that are in the hospital. Do you have any comments on that?
I think that once we have a working prototype with some data produced, that if people want to come and visualize that, some visitation can be arranged. We have to be careful though, because this is a healthcare environment. It's a healing environment, so you cannot have crowds. But one or two, interested visitors could certainly, have an observership organized so they could visit the patient rooms with patient permission, of course.
Yeah, and I think I would say part of what we try to do at least, is we try to spread the word, right, of the research. So that's something that we can help in the sense that we can do webinars, or we can do, write articles. We use a lot, Design Lighting magazine with Randy, where we publish a lot of our results. And it's more geared towards the designers. So part of our mission is also to educate designers. So we can try to make a bridge a little bit and help with not burden the hospital, but also trying to educate the designers as much as we can.
Okay, well, thank you, Dr. Figueiro. Dr. Rich, thank you. We'll go ahead and wrap here. Meantime, please do mark your calendar for 22 May. We've got Dr. Ray and Kevin Kempshire getting the job done, lighting for the new office paradigm. Thank you all.
Thank you.
Thank you.
Bye-bye.